Good evening, good afternoon, good morning, whatever time you're listening to this. We're going to talk about the cardiac assessment. Your goal is to use this PowerPoint to augment what you've looked at from uh, the book and the YouTube videos and the other references that's part of the class structure. So in the heart, we want to inspect, palpate, and auscultate. And when you auscultate, it's important for you to know that heart murmurs are graded at 1 to 6, and your goal is to determine what's the normal S1, S2, and then if you hear another sound, an extra sound, an S3 would be part of CHF. An S4 would be part of a STEMI. Once again, S3, CHF, and I remember that because CHF has 3 letters. And S4 is a gallop, and it's related to cardiac event. You may not hear the S3, you may not hear the S4. That's kind of what we have cardiologists for. If you go into cardiology as a nurse practitioner, you will hear that. The goal is for you to determine what is new in a patient, especially if they come in with a complaint of shortness of breath or anything that you consider cardiac or respiratory and cardiac. If it's chronic, if it causes symptoms. And so if you say it's a murmur and it's a 2 out of 6 and it's heard best at the right, at the left border, and somebody else hears it more at the tricuspid area, neither of you is right, neither of you is wrong unless you're the cardiologist. So the goal is to know what's normal, S1, S2. If you hear something different, always have another practitioner come and listen, especially initially, and then you can put that sound with the correct terminology and you can be better at what you do. The more you listen to heart sounds in people that are short, tall, thin, not so thin, young, old, not so old, very old, you'll listen to the different sounds that the heart makes, and you'll be able to understand there's a wide variety of what's normal and abnormal. Once again, you want to know if there's an acute change in the heart sound and if there are symptoms related to the acute change. We talk about chest pain and pressure. You want to rule out cardiac cause. The main one is a STEMI that could potentially kill you because heart time is muscle. If you fail to respond to appropriately to chest pain or pressure, and in the elderly female diabetic patient, it may only be shortness of breath, breathlessness, and anxiety when they present. Palpitations, we'll talk about what's benign and what's atrial fib. Fatigue, that's a patient's definition. You want to find out if a person comes in, if there's a cardiac origin. Dyspnea, shortness of breath, we talked about that in the respiratory, but we're going to talk about systemic causes, mainly CHF. It's important now to know acute on chronic CHF. There are penalties for a hospital readmitting a patient within 30 days of a CHF episode. So it's important to identify that initially. A syncopal event, and that's neurocardiogenic, and which is about 50% of your syncopal events. And rarely do we find, less than 30% of the time do we actually know why somebody has a neurocardiogenic syncopal event. We talk about leg pain and what is peripheral vascular disease, whether it's arterial or venous, and what are ABIs. And then edema, pitting or non-pitting. The way to cure edema is not Lasix, although you might have an argument with your patient on that. So heart anatomy, the heart comes into the right side, and the right atrium is a low pressure area, goes through your tricuspid valve, into your right ventricle, out your pulmonary valve, into the heart, into the lungs. And what happens in the lungs is CO2 is taken up by the red blood cells after the O2 is taken away, and the O2 goes to the cells where they need that to work. And then it comes back to the left side of the heart. If you were going to say what's the most important chamber of the heart, it would be your left ventricle. That's actually where the squeeze is, We talk about the atrial kick. Usually about 30%, 30 cc's of blood comes in the right atrium, and about 2/3 of that actually ends up leaving the left atrium out to the body, and this is called your ejection fraction. Normal ejection fraction is about 60%. An ejection fraction of 30-35, depending on who you talk about, usually leads to acute on chronic congestive heart failure. So with the left ventricle, that's the squeezing portion of the heart, and it's always important to know, is the left ventricle big? Is it thick? Remember, the heart only has 3 adaptive responses, and the one of them is tachycardia. In order to meet the metabolic needs of the body, the heart can increase the number of times it beats, but remember, if you increase the time it beats, there's less blood that goes out of the left atrium. The left ventricle to the body. It takes a certain amount of time for those 30 cc's or 20 to 30 cc's to leave. So the faster your heart beats, the less blood that's coming out of your heart with each beat. The other option that the heart has to deal with stress, and remember the definition of stress is asking for a change, is the heart becomes thicker, and that's called hypertrophy. And you'll see that a lot in a chest x-ray of a person who has hypertension that has not been treated with a goal of, depending on their age, 125 to 160 systolic, that they'll have LVH, left ventricular hypertrophy. That's thickened of the chamber. As the chamber gets thickened, the size actually decreases, so you have less blood flow. The left ventricle is able to accept less blood. So initially, LVH is adaptive, and in the long term, it's not adaptive. The heart doesn't work as well with LVH. The other option the heart has to deal with stress is to dilate, and when the heart dilates, it's thinner, and if it's thinner, it's more apt to rupture. So the 3 responses of the heart to stress is tachycardia, increased heart rate to meet the metabolic needs of the body. LVH is hypertrophy of the left ventricle, and then dilation of the heart chambers. None of those is particularly adaptive. There is a theory that when your heart starts beating, that will only beat so many times in your life, and then it will stop no matter what you do. And those of you who have ever worked in an arrest, you know it's much easier to restart a heart that's in either coarse or fine V-fib. If a heart's in asystole, you can use as much jump electrical power as you want, but the chance of it being coming back up is very slim. So once the heart stops, it stops. And heart disease is the main killer of female in the United States, and lung cancer is the main killer of males. And your goal is to extend the life of your heart. And so if your heart rate is 60 beats a minute, which should be your average heart rate, it will last longer than if your heart rate is 80 or 100. So tachycardia is, long-term tachycardia is not an adaptive response of the heart. This is the cardiovascular system. The arteries takes blood away, A for arteries, A for away. The veins bring it back to the heart. Reasons that veins don't work. Veins have valves, and the valves, as we get older, become incompetent. It's the main reason for edema in the lower extremities of people at the age of 50 and over. Lasix does not cure that. Once you have been diagnosed with obstructive coronary artery disease, meaning they've done a left heart cath and they've noted that you have thickening of the arteries, please note that that's thickening throughout your whole body. It's not particular to your heart. So if you have obstructive coronary artery disease, you as well have peripheral vascular disease and changes in the blood flow to your head as well. So you're going to have increase in intimal lining throughout your body. So the goal nowadays is to prevent cardiovascular disease as much as you can by eating healthy and exercising. The heart does age. The circulatory system of the infant prior to birth is a little different than afterwards. And now we talk about heart anomalies of the infant, and it's mainly structural, or they're in the right side of the body versus the left side of the body. Usually nowadays they do ultrasounds of infants if they think there is a problem, and they even do surgery on infants prior to delivery to change those structural components that are impaired. Although there are many adults now that actually have PFOs, and they're actually patched, and so that can happen. Circulatory system malfunctions can happen throughout your life. And there are specific cardiovascular changes related to aging, isolated systolic blood pressure, because those arteries get stiff, and the heart itself gets stiff, and so it doesn't relax as well in diastole as it normally did. So our heart evaluation is inspection, and you inspect the size of the body, the chest, the shape of the chest, the color of the person, and the sitting position. And we talked about that with respiratory. If you have a person that comes in and their color is just not good in terms of, and I ask you not to use the word good in any of your physical exam recording, but if their color of their body has changed, remember that people of color, they end up with cyanosis in their membranes of their mouth and their sclera. If there's a change in their color, they look pale to you, or if they have central cyanosis, which is blue tinged lips, that you know that there's a change in their cardiovascular system. If they're sitting hunched over or leaning forward so that they can breathe or relieve chest pain, i.e. pericarditis, then you know that there might be something wrong with the heart. So you look at the whole body. Is there a change in the shape? Are they very tall? Do they have acromegaly? Do they have Marfan syndrome? Are they very teeny tiny and have some type of genetic deformity? Remember that for some reason deformities usually come in 3. So if somebody has a change in their, like Klinefelter syndrome, or some of the other genetic abnormalities, the goal is to always look at the cardiovascular system, and then you palpate. And you can palpate the PMI, which is the tip of the left ventricle. If they have hypertrophy, it will be shift more towards the axilla. Although that's easy for me to say to you, not everybody can you palpate that on. It's very easy in a very thin person who's laying flat on the bed, not in an upward position at a 45 degrees, to actually see the tip of the left ventricle in the fifth intercostal space. But if a person has any fat on them, or they have breasts that are enlarged, you're not going to be able to see that, especially with pregnancy or COPD. Remember that your pulse strength is 0 to 4, and you're comparing the right versus the left, the upper extremities to the lower extremities. And then we'll talk about ankle brachial pressure index, which is very important for you to assess peripheral vascular disease. Many of the guidelines say that you can't wrap legs with an ACE wrap or put TED hose on until you've actually evaluated the ABI. Auscultate, it's easier if you ask them to hold their breath. I listen on people's back for their lungs, and then when I listen on their chest, I always tell them to hold their breath. And I do the TM, and I listen in all those 5 places. First, I listen to the right carotid, then left carotid, and then listen to those places. And many times people will ask you questions while you're listening, and which we all know that just the sound of their voice going up to your ears can be very, I don't know what word you want to apply to that. And so that's why I kind of ask them to hold their breath. It's actually easier for me to hear, and then I know they're not going to talk. Remember your carotids, S1 lub with the upstroke. You're going to listen to the heart, and then you're going to listen for aortic as well as femoral bruits or aneurysms. These are your heart sounds. S1 is your lub. It's the diaphragm. It's the atrioventricular closure. It's the onset of systole. Systole is your contraction. I just remember this. Is systole as diastolic is die, and if you're dead, you're relaxed. So that's how I remember that. And so dub is diastole, DD, and that's the S2, and you listen with the diaphragm. S3 is a bell. It follows S2. I'm not really great on S3. Remember that it goes with CHF, and S4 is a gallop, and it's the atrial kick. And a lot of times when people have a pacemaker placed that sets the pace of the heart, they miss their atrial kick, and so they don't get the exact squeeze they need at the end of the systole. Once again, this is your lub-dub. You need to know this for the test. You need to know this for life. Which is systole? Which is diastole? Where do you hear it, at the apex or the base? Then we talk about heart sounds. And once again, your heart sound is S1, S2, and how you record that is S1, S2, no MRGs, no murmurs, rubs, or gallops. S1, S2, no murmurs, rubs, or gallops. Now, what is a heart murmur? And a murmur is a sound of the blood going through a turbulent area. It's related to either a stenotic, a valve, or a valve that which is narrowed due to aging or some trauma, or a valve that fails to close, which causes regurg. I always I use the phrases when people ask about their heart. I say your heart has 4 rooms, and there's doors between each of the rooms. And when those doors close and then come back open, that is called regurg. So you hear a swoosh when the blood flows back into the chamber that the blood just came out of. Once again, these are the areas to listen to that. You want to know the timing, the intensity, the pattern, the location. Does it radiate? And I just say, remember Mr. Ass, and Mr. Ass is mitral regurg, aortic stenosis, and those are your systolic murmurs. The main one you're going to hear in the elderly is aortic stenosis. As the heart ages, it changes shape, and as the heart changes shape, those valves do not close with the same dexterity. And so that's where you have regurg and regurg. And the other is stenosis is related to LVH, left ventricular hypertrophy, cardiomyopathy, some damage or trauma or insult to the heart. Peripheral vascular disease. We've talked about the heart, looking at the heart, the carotids. You want to inspect the skin color, if they're pallor, if they're brown. And brown is usually hemosiderin in lots of people that are diabetic and overweight and have obstructive coronary disease. You note the brown tinge on their lower extremities, and this is where the vascular system has penetrated the skin and they have a change in color. Usually if it's brown, they're also dry, so the texture is changed as well as the skin color. You want to inspect for varicosities, where they start, are they painful? Nowadays, I think they only pay, or insurance pays, for painful varicosities versus non-painful varicosities, so you have to ask about that. And varicosities, it's a combination of smoking, activity or failure to act, weight, as well as smoking. And you will see the site of previous ulcers. And then you palpate the temperature, comparing the right with the left. I saw a lady today who was on dialysis, and she has pain in her left foot. And I treated her last week, and I really thought, because she's a long-term diabetic, that it was neuropathic. And so we gave her gabapentin and we increased it from 100 to 300, and there was no change. And usually with peripheral neuropathy, you have about the same pain in the right and the left. But today she was on dialysis, and the left foot was really hurting her. So I took off the socks, and I felt in the left foot was much cooler than the right foot, and I couldn't palpate a pulse. And she had ABIs on yesterday, and it showed severe stenosis. And so I consulted cardiology. So it's important for you to feel the temperature on the right versus the left, starting at the feet and going up to the upper part of the leg as well as the arms. Now, the capillary test, once again, I've said that I don't think it's a very clear test to tell how much blood flow is in an area. If people have fake nails, you're not going to get that. If they're into pedicures, you're not going to see that on the foot. But if you have some people that the toe is purple, and then you know that their capillary refill is off. There's another test called the Berger's test, and you're looking to see if you raise the leg about 45 degrees, and if they have pallor, you know they have changes in their blood flow. The main thing I want you to know about palpitation is temperature, varicosities, the aorta, and the peripheral pulses. And so you want to palpate varicosities, you want to feel them, you want to see where their origin is, where they end up, and is it painful. You want to palpate the abdominal aorta. But let me be a little clear on palpitation. Now, if you have somebody who comes in, and we'll talk about this with the abdomen, and they have an enlarged liver, you don't want to do a soft and a hard palpitation of that liver and it rupture for you, and or spleen. So sometimes it's nice to know where you think the edge of that spleen is, where that liver is, or before I ever palpate abdominal area, I listen. And if I hear a bruit and I put my hand over there and feel a thrill, then I'm going to be less likely to put my hands on both sides of the aorta and press down. Once again, listen first. If you hear a bruit, if you put your hand gently on the aorta and you feel a thrill, you're not going to palpate it. You're just going to put your hand there. The other is nowadays that you need to know the screening guidelines. I think it's over age 50, a male with a smoker, and they just watch abdominal aortas. The question is, do you operate at 4.5 centimeters? Do you not? And then you palpate peripheral pulses. Now, do you actually feel the brachial, the radial, the femoral, the popliteal, the DP, and the PT? Well, here's what I feel. If I get down to the PT, if I've got blood flow in the PT, I'm assuming correctly that I have blood flow in the popliteal as well as the femoral. And if I have blood flow in my brachial, then I'm sure I have it higher up in the arms. So I just compare the right and the left wrist and the right and the left foot. And if I feel, and it's 0 to 4 out of 4, if I feel 2 out of 4 on both sides, then I'm pretty sure that they have good peripheral pulses. Once again, it depends on how good you are with feeling, if you use firm pressure versus gentle pressure, if you use the tips of your fingers or not. And then you auscultate, and once again, femoral and aortic bruits. And this depends on what somebody's chief complaint is. Once again, if they have obstructive coronary disease and they come into you with chest pain, pressure, palpitations, and you're doing a full exam, or if in their hospital, you have nothing to lose by listening over those areas. So with the peripheral vascular assessment, you should know where the pulses is. Once again, if you feel the radial, you can assume that they've got appropriate brachials. If you feel either dorsalis pedis or posterior tibial, then you assume that they have femoral. On the carotids, I listen over the carotids. I don't palpate the carotids. And you can ask your preceptor about this. Once again, the arterial system takes blood to the area. It can be obstructive through stenosis or a tumor in the body so that blood doesn't go there. Usually that's an immediate change in the color and the sensation. It's an acute problem, arterial occlusion. Venous occlusion takes a little longer for there to be a problem because there's so many more ways that the blood can get back to the heart. Even people that have DVTs who come in, you listen to their symptoms, and this has gone on for quite a while. Once again, arterial system occlusions for cardiovascular disease are acute, arterial, acute. They need to be worked up immediately. The venous systems also need to be worked up, but usually there's a variety of causes, V for venous, V for variety, and this is, for many people, a chronic problem. So what are the cardiovascular problems that present here in the United States? And the first one is hypertension. And I've given the two websites. One is the JN7, and it talks about how do you define hypertension, and there's the JNC guidelines, and the JN8. JNC8 has yet to come out, and the goal is 2 or more blood pressures with the bottom number 90 or above and the top 140 or above. And this is really based on age and appropriate cuff size. Now, consistently, I find that people don't take blood pressures well. You'll find some people that like cuff pressures. Some people use the right arm. Some people use the left arm. Some people take the blood pressure sitting. Some people take it standing. Your goal is to know how to take a blood pressure, and the arm should be at the same level of the heart. That's the best way. If somebody comes in your office and they have an elevated blood pressure, and for most people that's 160 over 90, please note that you have to take another blood pressure on that patient before they leave the office. And you need to know in your office setting or your hospital setting what is a blood pressure that causes immediate concern, hypertensive emergency. It used to be systolic above 180. I work in dialysis, and we have people that come in with 240. It's chronic. I'm not excited about them. But when you read in your undergraduate books, 180 was fixing to be a stroke. So you have to know what are the extremes in your particular facility and what do you need to do about it. Now, in one of the offices I work, we have no drugs. So if somebody comes in with the 220, I can't give them anything to bring it down. And the drug of choice to bring it down is, if the people carry their drugs, is to take what they didn't take that morning. I have so many patients come in and they go, oh, no, I fasted before the office visit. And no, I didn't take my blood pressure medicines, and I would like them to take their blood pressures immediately. And then if you have clonidine, clonidine will bring it down. But you have to know what is their normal blood pressure. And when we talk about hypertension, we talk about, and I just saw that was spelled wrong. When we talk about hypertension, we talk about the white coat syndrome, whether they have hypertension in the office or out of the office. The only way for you to know is to have a patient-centered discussion and explain to the patient that you would like blood pressure recordings from out of the office so that you can treat the average blood pressure versus the highs and the lows. Explain that to the patient. See if they will bring that in. Now, I have many patients that can't afford the copay for the blood pressure machine, so I ask them, is there some place they visit routinely? Can they go in and use that same blood pressure cuff, record those and bring those in? They can drop them by the office. They can fax them. They can email it. I think, don't 10% of your patients have to respond to you by email now for PQRST? So your goal is to find out what is high blood pressure, what is their blood pressure at home. If they have either low blood pressure or high blood pressure, you want them to take their blood pressure 2 hours after they take their drugs, sitting and standing. But the goal of this particular section today in cardiovascular session is for you to know what is hypertension and how it affects different parts of the body, and for you to know that JNC7 is your guidelines for hypertension. There's 6 different drug assortments that we can use to treat hypertension, and they're usually ethnic related. It used to be beta blockers were the number one, and now it's ACE, ARB, and/or diuretic. Once again, I've just showed you the high blood pressure changes. I have patients that come in and say, because hypertension, we say there's a secondary hypertension, which may be related to stenosis. Renal artery stenosis is a cause, or an adrenal tumor or pheochromocytoma. But then there is essential high blood pressure, and the joke is 85% of blood pressure is essential. And we say essentially, I don't know what you got it, why you got it, you just have it. It can be related to age, gender, and ethnicity. When we talk about weight gain and blood pressure, you know that some guidelines say that if somebody's 100 pounds overweight, which is considered morbid obesity, that some insurances will pay for some type of bariatric surgery. And many people, when they lose weight initially, can come off their blood pressure medications or decrease their blood pressure medications. So you should know that there is blood pressure related to weight. I tell people if they go up 5 or 10 pounds that they may need to go up or down on their blood pressure medications. Another, if you work with the elderly, it's important to know when they take their blood pressures in the morning or the night, especially thin, frail people. If a 85-year-old female who is 120 pounds, who is on 3 medications for blood pressure, which is the average number of medications, and they wake up with nausea and vomiting, and the first thing they do is put those blood pressure medications in their mouth, and then they don't eat or drink during the day, they can end up with acute kidney injury. So talk to your patients about when they take their blood pressure medications and what to do on a sick day. Once again, symptoms for high blood pressure, there aren't any. The old adage that you'd have vision changes and headaches related to high blood pressure is not true. It doesn't, there is no evidence base for that. The only way we know that they have high blood pressure is to take the blood pressure. Heart disease, when we talk about heart disease, the goal is, can we prevent obstructive coronary disease and make people live longer? So what you have to do is a cardiovascular risk assessment. And the most common one is the Framingham risk. And you can do it at 10 years or 20 years, and you find out if they're high risk, moderate risk, low risk for having a cardiac event in the next 10 years or the 20 years. And then you can determine which of those risk factors, modifiable versus non-modifiable, that they are willing to change. A non-modifiable risk factor would be gender, ethnicity, and positive family history. When we talk about a positive family history, that is a male below the age of 45, first-degree relative that had a cardiac event, a woman below the age of 55 who had a cardiac event. Once again, that puts you in a different category. If we say, did anybody in your family have heart disease? If you're a female, the answer is going to be yes, because heart disease is the leading killer of females. So the goal is to find out, is there modifiable, non-modifiable risk factors? What is their risk in 10 years? What is their risk in 20 years? What are they willing to change? So what are the things that a person can change to decrease their heart disease? And the number one thing is smoking. Smoking increases your heart disease 6 times that of another person with the same age and gender and comorbidities. A non-modifiable risk factor for heart disease is diabetes, and a risk factor of diabetes equates to heart disease. You don't have diabetes without heart disease. What is modifiable is what is your average blood glucose. If you've been diagnosed with diabetes, your goal is around between 6 and 7 in the first 5 to 10 years. If you've had it for more than 10 years, the goal is 6 to 7. That's your average hemoglobin A1C. Once again, heart disease, what is modifiable, What is non-modifiable? Have we done a risk calculation to determine what is the risk in the next 10 years, the next 20 years? What can they do to decrease their risk of a cardiac event? So besides not smoking, the other thing to do is move. Move, move, move. Whether it's 15 minutes a day, 20 minutes a day, not quite sure why women have to exercise 6 to 7 days a week. Men only have to exercise 5 days a week, and the other is portion size. So it's the type of calories that you put in, whether it's Mediterranean diet or low carb or high carb or chocolate when you're feeling antsy. As a female, you have to know if you drink one glass of wine a day, it increases your risk for breast cancer. And you can use the Gale risk assessment for breast cancer. Wine a day for men is considered, I think it's flavonoid, will decrease your risk for heart disease. When we talk about evidence-based medicine, just for you to know that women probably up until the 80s were not included in any research. And the reason was when companies were doing research on their drugs to determine if it changed the mortality or morbidity of patients after a certain amount of time. They did not include women because women of childbearing age, if they got pregnant on the drug company would have to pay for the child if they had any diseases. So drug companies, for the most part, did not include women in drug studies for years. And then they changed that policy. They've included women, so now we have more research on women. Women are different than men. Aren't you glad I told you that? Whether you need a aspirin a day after the age of 65 to decrease your chance of breast cancer depends on if you're male or female. If you need to have aspirin 81 milligrams a day for 20 years to decrease the chance of colorectal cancer, that is gender, ethnicity, and age dependent. I talked to some cardiovascular cardiologist, and the question is, does an aspirin a day actually keep a heart attack away? And how much aspirin? Is it 42, 81, 162, 325? And I had one doctor said he takes a lick of aspirin and then tosses it, and he thinks that's enough. Chest pain or pressure, remember those words are interchangeable. The goal is to turn out, is it a deadly event? Is it something that's going to kill the patient? So when you have chest pain, is it cardiac in origin, STEMI versus non-STEMI because time is muscle, or is it a pulmonary emboli? This is the chest pain flow chart. Once again, the point of this part of the lecture is for you to recognize with chest pain, you want to rule out an acute coronary syndrome. And if it is that, to get them to 911 and do the MONA as quick as possible. Another flow chart, I really do like flow charts. This is stable angina, unstable angina, acute coronary syndrome. Stable angina is usually when you have chest pain pressure with activity that resolves completely at rest, and this is a person who has a history of obstructive coronary disease. Unstable angina in a female, especially a diabetic, can present as anxiety, shortness of breath, breathlessness, awaking in the middle of the night, just feeling anxious. With men, there's a positive Miller sign when they take their fist and they throw it to their chest. It happens for 20 to 30 minutes. It increases in intensity. It radiates to the jaw, goes to their back. They have nausea and vomiting, other symptoms. The easiest way to determine that is to do an EKG. You have 2 millimeter ST elevation in 2 or more contiguous leads. Once again, you find out on all your patients, you do a Framingham risk category and determine if they're in low, moderate, and high risk. and no, the sensitivity and specificity of neither of those charts is not 90%. This is a value of a flow chart. Where is my car? I have seen a flow chart on how a woman's brain works, but I can't get it to come into Wimba with all those little motions. Another common presentation that's cardiac and for a symptomatology when a patient comes to your office and you're going to do a complete health history to include a PQRST or a flow chart to get the HPI down along with risk factors is fatigue. Now, the causes of fatigue are many. The main thing you want to determine is how much fatigue do you have? When do you go to bed? Do you wake up rested? Are you able to engage in your normal activities? And if you can't, what exactly can you do during the day? So the goal is to find out what is the cause of a fatigue flow chart. And why I put that in here is that for many women, when they come in fatigued, and this is a new onset of acute fatigue, it means that they've had a cardiac event. So keep that in mind. And this is dyspnea. I gave that to you last week in respiratory, and this is another one. Dyspnea can be a cardiac event, can be a pulmonary event, it can be a little of both. So if I said, what are some common presentations of cardiovascular diseases? One would be fatigue, one would be chest pain and pressure, one would be dyspnea. This is your dyspnea flow chart, and you'll find out in any flow chart, you want a history, a physical exam. In a history, you want to do the PQRS, the old cart, and look at the risk factors for any of the differential diagnoses that you are considering. Syncopal events. Now, there are two types of main syncopal events. One is I'm fixing to faint and I do, and the other is you just go down. And it's hard to figure out those two events. But when somebody comes in the hospital in a syncopal event, why they're coming to the hospital is you want to find out, is it neurogenic, neurocardiogenic? Is it there a reversible cause so it doesn't happen again? And depending on your state, if you have two syncopal unexplained events, your driving is restricted. Now, in our hospital, if somebody comes in with a syncopal event and they have a tilt table test that is non-diagnostic, but they had a syncopal event that really was, I'll give you an example. We had a 26-year-old lady that remembers driving to work, and she worked at a golf course, and she said hi to a person out on the golf course, and the next thing she knew is somebody was taking her out of her car because she ran into a tree. Now, that's a true syncopal event, and she was not allowed to drive until the cause was determined. So she went to an EP, which is a cardiovascular cardiologist who is specialized in electrophysiology. She wore a loop monitor to find out if she was having some type of Wolff-Parkinson-White or some type of cardiac arrhythmia or dysrhythmia, depending on what part of the country you are, whether you use dysrhythmia or arrhythmia, before she could drive. You'll find with young people, 18 to 22-year-olds, they have a panic attack. And those are persons that say all of a sudden they feel a dooming sensation. They feel their vision is tunneling, and they start to hyperventilate, and they pull off on the side of the road, and then they pass out. Two different types of syncopal events. But when people come in the hospital, the main goal is to figure out, was it a cardiac event, a pulmonary emboli? Both of those are deadly, that cause the syncopal event. If both of those are ruled out, then the next thing is the determining if they have hypotensive or autonomic dysreflexia or dystonia, and you usually do that with the tilt table test. So when people come in with a syncopal event, who do we consult? Cardiologist, neurologist, to rule out a cardiac event, a PE, and a stroke. These are the types of syncope. Another syncopal flow chart. Once again, I'm not asking you to memorize these flow charts. I'm giving you the words to use. Is the cause of a syncopal event? Please explain it to me. Did you pass out, or were you fixing to pass out? Okay, what happened prior to you passing out? Then the goal is to rule out a life-threatening emergency, which would be a pulmonary emboli or a cardiac event, and then to rule out stroke. You consult cardiology, you consult neurology. We're almost finished. The next thing is palpitation, and there's benign and pathological. When our heart beats, the blood flows into the left ventricle, and as the left ventricle squeezes, and that's about 60 times a minute, you should not feel that. But sometimes we feel it. What are the reasons we feel it? Well, sometimes the heart does not work as perfectly as other times, and there's a delay in the squeeze. So the heart during systole, a little bit more blood than the normal 30 cc's goes into the left ventricle. So when it squeezes, because that's the Frank Starling law, the pressure gradient, it squeezes a little bit more, and you're aware of it. And that's called a palpitation. You're lying in bed at night, you're thinking about the midterm exam and health assessment, and you're wondering if you're going to do okay on it, and you overdid on the chocolate and the caffeine today because you had to do the laundry, buy the groceries, make the meal, pack the lunch, work for 8 hours, and read or listen to the cardiac event, and you're laying in bed, and all of a sudden you think your heart is irregular and it's coming out your throat. So the goal is that palpitation benign, meaning it's not pathological, not going to kill you, or is it a symptom of SVT or atrial fib? We don't know until you come in. We do an EKG and or a Holter monitor. Most everybody has felt their heart beat now and then. And some people have numerous benign palpitations, and if you see them on an EKG, you see them as PVCs or PACs. Now, the palpitation that is problematic for many people is atrial fib, but less than 50% of people with atrial fib, and that is, I call it the funky chicken act, when the electrical system of the heart fires erratically and the heart goes into fibrillation, it kind of just quivers rather than pumping effectively. 5 out of 10 people feel this. And what they actually feel is they suddenly feel anxious, and they feel like their heart is in their throat, and they feel that their heart is beating erratically. 5 out of 10 people feel nothing. How they know they're in atrial fib is they come in with a stroke, and as they're doing the assessment in the emergency room, they are in atrial fib. They've never felt it. They've probably been in it for over 72 hours. They've had a mural thrombi that has gone to their brain and caused a stroke. So in atrial fib, what you want to rule is it valvular, non-valvular, and you do this through an echo. And if it's non-valvular, the goal is to call in an EP and figure out, is there a drug to decrease the rate of the heart or the rhythm? And that's called the Accord trial. and it looks at, is there a difference in the outcome of mortality and morbidity between changing the rate in atrial fib or changing the rhythm in atrial fib, and there isn't. Your goal is, if someone's in permanent or paroxysmal atrial fib, is to prevent a stroke. And you do this through anticoagulation, and depending on your facility, those choices, there's a variety of choices, and I'm not going to go into that today, but that is the goal, is stroke prevention through atrial fib. You can change the heart rate if you get the heart rate down to 60 with a beta blocker, BETA. And remember that word, if you flip it around, is beat. So you block the beat of the heart so it stays around 60. And if it stays at 60, it decreases the chance your heart will get in atrial fibrillation. If you can't control the heart rate, you may be able to control the rhythm. And those are with a variety of drugs. The most common is amiodarone. Both of those therapies, there's benefits and the risk. Most of the patients, and I've worked with an electrophysiologist, most of those patients who are symptomatic want it cured. It's rarely cured. Even with the electrical physiologist going in there and burning, it doesn't always work. Leg cramps and pain. Many young children have leg cramps related to aging. Many diabetics have leg cramps related to neuropathy. There are many people that have leg cramps. Once you have a leg cramp, it can become from an acute condition to a chronic condition. It doesn't really have to do with how much potassium is in your body or magnesium is in your body. Quinine used to be the drug of choice that was sold over the counter. That's not available anymore. You can look up to see what are the old wives' tales that people use to decrease the chance of leg cramps. I've heard silver spoon. I've heard soap in the bed. I've heard drinking tonic water or quinine water at night. Those people who have leg cramps, the more you have, the more you have. There's no real treatment. Although some people use gabapentin, and then other people treat it with a drug they use for restless leg syndrome. So your goal in leg pain is to determine, is it peripheral vascular disease, arterial occlusion that is causing the leg pain. So you do the ABI. This tells you how to do it. Once again, we're talking about peripheral vascular disease, arterial occlusion, venous valve. Your goal is to be the best diagnostician you can, no matter which of these young men you like best. For Sherlock Holmes, if you've seen those movies, they can look at a situation and take in lots of cues at one time and find the meaning. I have been around excellent diagnosticians. Hopefully your preceptor is an excellent diagnostician. You can learn what questions they ask in the PQRST, what follow questions they ask, and how they come up with their answers. Edema, you got your pitting, you got your non-pitting. For most people, edema is multifactorial. It's due to valvular incompetence, sleep apnea, obesity, and lack of movement. So when somebody has edema, your goal is to find out, is the right equivalent to the left? And for most people, they're similar right versus the left, not exactly the same. If you've had trauma in the hip, knee, or ankle of one leg, you'll probably have more swelling because you have vascular or venous compromise due to the trauma. If you have one leg that's much more swollen than the other, you always think about DVT. We talk about the Homan sign, but that sensitivity and specificity is so low that I wouldn't call it diagnostic. Usually you do a D-dimer, but you do an ultrasound of the lower extremity if you're trying to rule out on DVT. You have to do an ABI, and they can't have vascular compromise in order for you to recommend TED hose. Now, have any of you ever tried to put the TED hose on? When you read the chart, it says you're supposed to lie in bed, put your feet straight up for 5 minutes so all the blood flows to your pelvic area, and then you slowly put those stockings on prior to getting out of the bed. Now, most of the people that I know that have edema are people that wait to the very last moment and they get out of bed and run to the bathroom. These are not people that are going to wake up 10 minutes early and put that stocking on them. I think they're extremely hard to put on. Some people will wrap their legs, and then some people actually can get reimbursed for using those compression that are on lymphedema garments that actually have the tunnels of air that compress and decompress, and they're put on with Velcro, and they use them at night, and it helps with the edema. Now, because I work with people who have kidney problems, my first question to ask them is, how much fluid do you drink a day? And if somebody comes in and they drink 4 liters, and a liter is 2.2 pounds, and they don't move, I explain to them as soon as they stand up, they drink all this, the fluid goes down to their legs, and the only way to get it out of their legs is to put their head, stand on their head for 15 to 20 minutes, or lay on the ground and put their feet up the wall so the blood flows down. I haven't had any takers on either of those situations, so we try to decrease fluids. Everyone wants Lasix. They talk about my feet swell, give me Lasix, give me Lasix, give me Lasix. Now, when we're talking about edema, you do want to know if somebody has acute edema, if somebody has obstructive coronary disease, if they have compensated congestive heart failure, and over the last 2 days, they've increased their weight over 5 pounds. And these are people that you talk about daily weight and increasing their Lasix, are using metolazone prior to the Lasix to get the fluid off. That's a little different category. So what we've talked about in this is the heart. We inspect, and this is the color. We palpate the peripheral pulses, the varicosities, and the aorta and femoral area. We auscultate the carotids, the heart, the femoral, and the aorta. We listen to the hearts of all sizes to know what is the S1, S2, S3, congestive heart failure. S4, gallop, is acute coronary system. We know chest pain and pressure. You want to rule out the cardiac causes, acute coronary syndrome, which is unstable angina, and it's a STEMI or a non-STEMI. It's life-threatening, life-limiting, and or PE. Those are deadly diseases. You want to rule those out. Palpitations, benign, meaning you have those. There's no cause. Atrial fib, we do rate or rhythm. We determine if it's valvular versus non-valvular. Fatigue is the patient's definition. Why I brought that up is many females come in with acute onset fatigue, and it's actually a cardiac event. Dyspnea, shortness of breath. You want to know, is there a systemic cause or if there's a specific system cause, cardiac versus pulmonary. Syncopal event, which is neurocardiogenic. You want to know, did they knew they were fixing to the faint, or did they faint right away? You want to determine if it was a heart attack, if it was a PE, if it was a stroke, and for the most part, we may not know what the diagnosis is. For leg pain, You want to find out if it's acute, if it's chronic, if the cause is related to PAD or PVD. On edema, you want to determine if it's valvular incompetence, if it's multifactorial relating to weight, fluid intake, and failure to move. Thank you, and I hope this has been helpful to understand cardiac assessment.